Matthew Weinstock reporting from the 26th Annual Rural Healthcare Leadership Conference in Phoenix, Arizona. One of the key themes being discussed among the executives and trustees in attendance is clinical integration. As healthcare moves towards a value-driven model, hospitals and physicians really need to do a more effective job of collaborating. Joining me now to talk about hospital-physician relations is Russ Johnson, CEO of San Luis Valley Regional Medical Center in Alamosa, Colorado. Russ, thanks for being with me today.
Great to be here. Thank you for asking.
One of the things I want to talk to you about is this idea of clinical integration. You have a tweener-sized hospital out there in Colorado. Talk to me a little bit about what you've been doing with your physicians and integrating them into the hospital.
We really see the future of our hospital being that integration between how we work with our physicians. So we're really putting that at every level we can. From governance, I have 11 board members, and 4 of those are physicians. 3 of those are actually employed physicians, so we have a commitment to having our physician leadership at governance. For a smaller organization, it's a little unusual to have a chief medical officer, but we have made a commitment to that. And then we've also a little bit different, I think, Matthew, is we have established what we call a Physician Leadership Council, which really is a governing body over our physician practices, how they operate. They approve and build our compensation model. They put together expectations for clinic performance and oversee our contract and our recruitment plan. Of course, then we also use physicians deeply in terms of clinical excellence, all of our quality measures, our IT leadership teams, almost every area where we can embed a physician into a decision-making process, whether it's clinical or more strategic operational, that's what we're trying to do.
And was that a conscious move? And if so, what was sort of the tipping point where you said, boy, we've really got to get physicians into some of these leadership roles?
It became a conscious move. So what precipitated our relationship, our really expanded relationship with physicians, is we had a large multi-specialty clinic come to us and say, you know, we're not going to make it on our own. And they became part of the hospital. And at the time, really, I had, and our organization had a lot of trepidation about that, because it's the hospitals have sort of a long and not glorious history of managing and having physicians be embedded in the organization. But after about a year, what we really realized, to your point, was that this is our future. And we wanted to do everything we could to not commoditize, if that's the right word, our physicians, and to have them feel like they were just there to drive volume and to admit patients and order MRIs. So that became very much a consciousness of ours, and from there, over the last 3 or 4 or 5 years, really a strategic direction for us.
So Russ, as you talk to some of your colleagues, both here in Phoenix and across the country, what are some of the best practices you've really employed in integrating the physicians into the hospital?
While it may be intuitive, the governance piece is just critical. So starting there and having that be part of your organization. Another thing that's important to us is the initial recruitment process. And we try to think about physicians wanting to be have a shared purpose with us. We use that word in recruitment is, do we share this mission and this goal together? And I think that's really a critical part of it, because not everybody wants to identify with their organization and be a part of it. Sometimes they just want to be employed and have a low-risk practice model. Another practice that we've employed that I think has been effective is in the information technology arena, which is so vital in our strategy. And so having physicians part of our super user and more than just advisory capacity, where they're really guiding and directing, and at times selecting which kind of strategic information product we go with, or how we implement it, or what our timeline is.
So one of the other themes we've been hearing all week here at the conference is sort of the role of the independent hospital, especially the tweeners, right, as we move toward a value-driven, accountable care type of system. Talk a little bit about where you see rurals fitting into this new model of delivery.
We decided about 3 years ago that although we're not a small rural hospital, we felt like we needed a strategic partner. And while our balance sheet was strong and while we have good performance, now was the time for us to make that decision to connect with a bigger partner. So we actually went out and courted partners, and rather than waiting to come to us. But I think what the questions I see hospitals thinking through is, can they survive independently? And what I would encourage them to ask is, should they survive independently? Because I think a lot of hospitals can survive. You know, they can dig in their claws and they can hold on for dear life, and feels like they can do that for a long time. But I think the question we had wasn't, can we? But are we going to be a better organization if we have a partner maybe that doesn't own us or doesn't govern us, but is a clinical partner and helps us with the challenges we see in our community that we just can't solve on our own.
One of the things you talked about, Russ, on a panel you were part of the other day was the role that you're playing in the health insurance exchange in Colorado. Your governor has decided to move forward with that.
Yes.
How do you see hospitals fitting into that conversation about the exchanges?
For us, the exchange and the expansion of access through, whether it's through the Medicaid component or through the sliding scale and the exchange aspect, is really important. We have a very large, currently uninsured population. The way I see us fitting in is almost being their marketing and enrollment arm, and really getting to know the exchange product so that the people in our admissions or front end or in our clinics can refer a family or an individual who may be a candidate for a subsidized product or for an expanded Medicaid product to get in that, because that coverage is pretty highly correlated with people getting primary care and preventive care. So we want very much to be a partner with the exchange. We have a website in our community that we developed a couple of years ago that is really about helping people understand how healthcare works, and we want to promote the exchange on that and work very closely with them so that people in our community who may be reluctant to enroll or may just not know about it are familiar as we can make them, and we end up moving from 25% of our people who don't have coverage to 5% maybe.
Well, Russ, I really appreciate you taking some time to talk to us today.
Just absolutely my pleasure.
I'm Matthew Weinstock. This concludes our coverage from the 26th Annual Rural Healthcare Leadership Conference. Thanks for tuning in.